Good afternoon. Today I will be presenting the management of a case of cataract surgery complication. We have a 76-year-old male, diabetic and hypertensive, who presented with pain, redness and loss of vision in his left eye after undergoing cataract surgery 2 months ago elsewhere. His significant findings were in the left eye, a BCV of PL positive, PR accurate. He had corneal decompensation with iris prolapse, a flat anterior chamber. And what was surprising was that there was a crystalline lens in the anterior chamber, as can be seen in this image, along with corneal decompensation. A USG of his left eye showed retinal detachment. He was subsequently started on topical anti-glaucoma, steroid, antibiotic and cycloplegic medications, and we reached a provisional diagnosis of left eye decompensated cornea with anterior displacement of nucleus, total retinal detachment with severe proliferative vitreoretinopathy. He was taken up for surgery. At first, wound reconstruction was done with repair of iris prolapse, followed by anterior vitrectomy, removal of vitreous strands. Nucleus was prolapsed into AC and it was removed with the help of irrigating vectis. Followed by that, AC maintainer was introduced, membrane dissection was done, and severe anterior PVR changes with closed funnel RD was noted. Again, a surprise, an intraocular lens was seen lying on the retina with one haptic subretinally. Membrane was dissected and it was removed. Now, due to poor visibility, we could not proceed further, and a decision of optical PKP was taken. The patient was taken up for OT 10 days later. Optical PKP was done, and an 8 mm graft was placed with interrupted sutures. Because of choroidal effusion and anterior displacement of retina, through limbal approach, repair of RD was attempted. PFCL was injected, but the retina could not be settled because of presence of fixed fold. So PFCL was kept in situ, and 2 weeks later, the patient was again taken up. Through pars plana approach, it was seen that the retina was settled at the posterior pole. However, because of thick peripheral folds, retinectomy 270° was done. Further PFCL was introduced and endolaser was done, followed by direct PFCL silicone oil exchange. Post-op 3 months, the patient had a clear corneal graft with no loose suture and the retina was attached. This was a unique case where the crystalline lens was found in the AC and IOL was seen on the retina, and it was initially thought to be a hopeless case, but it could be managed successfully.
So, how did you prevented the oil to come in the NTS segment and to touch the cornea? What did you do at the end of the surgery to push the oil behind? Oil touch करेगा ना, केराटोपैथी हो जाएगी, सिलिकॉन ऑयल केराटो, ग्राफ्ट खत्म हो जाएगा, तो क्या किया उसमें?
The AC was formed with air.
तो फिर से आ जाएगी, एयर तो एब्जॉर्ब हो जाएगी.
A YAC-PI was done.
चलो, it's
You do the inverse
not a,
PI.
huh?
Basically, you do the inverse PI to prevent secondary glaucoma, and a positioning at the time of filling the oil, you make sure that it doesn't come in the anterior chamber. Overfilling should not be done.
It's a super specialty question, so I can't
But
expect you to.
That is to prevent the glaucoma. Inferior PI has to be done. Reverse PI has to be done. But excellent surgery, I must say. Amazing job done. Generally, these cases are discarded and not taken up for the surgery. But amazing, excellent done, excellent work. Good.
Thank you, sir.